So my name is Rachel Johnson, and I am the lead speech-language pathologist at my clinic, Orthopedic Rehab. And I'm the lead because I'm the only one, so I took that title by myself. I just want to say that any of the videos or materials used today have written consent from the patients, and I just want to thank them for helping us learn. Can you guys hear me okay? Yeah? Okay. So that Amber gave a really nice summary of where I come from, but when I started in Wisconsin after graduate school, I was working inpatient in rehab, and I remember there was this dreaded, oh, the person has Parkinson's, I'm not LSVT certified, I don't know what to do with this patient. And so from there I thought, well, I'd like to really know what to do with individuals with Parkinson's disease. So I moved to the Milwaukee area, and in Milwaukee they had a movement disorders clinic, and two of the neurologists there were really specialized in Parkinson's. And so they would send a lot of referrals. So I thought that must be the time to really learn about this population. I just kind of want to get a synopsis of where people are at. So do a lot of you treat Parkinson's? Just raise your hand. Okay, are you seeing them in an inpatient setting? Inpatient, okay, and then outpatient? Okay. Say that one more time.
Long-term care.
Long-term care, okay, perfect. And so I wanted to put together a little summary of the evaluation and treatment of these individuals. And so you have kind of a tool bag of different evaluation protocols and treatments that you can use with this population. And I don't have any financial interest in any of the products or protocols I'm going to talk to you about today. Some of them I use, some of them are just information of resources that you can use. So I work for Orthopedic Rehab Associates, and the name doesn't really serve for what I do, but we do have a neurophysical therapist and myself, and we created the Neuro Rehab project. And it's really a program to kind of be a comprehensive resource and center that patients with neurologic conditions can come to. I would say that my caseload is 80% people with Parkinson's and the other 20% other neurologic conditions. At our clinic, we provide skilled speech therapy, physical therapy, we have orthopedic therapists, and I guess in the hospital settings, I never really met a lot of orthotherapists, but having them as a resource has been wonderful. They've done some kinesiotaping due to dystonia, they've helped with neck stiffness, movement, and so it's been a really good kind of community that we've created there. The learning objectives, kind of what I explained, I want you to feel comfortable recognizing the motor and non-motor characteristics of Parkinson's disease. Feel comfortable with selecting an appropriate protocol for these patients or treatment procedure, and selecting and I guess knowing what type of feedback really works with this population. So you all have a case history in front of you, and these were unedited, written by some current patients that I'm working with. And on that case history, what I wanted them to do is just write who they were. Where did you come from? You know, what's your background? And then they circled their initial, I guess, symptoms when they were first diagnosed. So some of you have a case history of people who had seen multiple neurologists prior to getting diagnosed. Some of them started with swallowing related issues, and then they were later diagnosed with Parkinson's. But I want you to really consider some factors when we first meet somebody with Parkinson's. Obviously their baseline function. Who are these people? I mean, we have a retired physician, a mathematician, a pianist, very talented, well-respected individuals. You know, the question I always ask, and I think therapists ask, is it time to start speech therapy? You know, is this person appropriate and showing enough deficit to justify the services? Obviously thinking about selecting the appropriate evaluation and treatment, baseline testing, so think about what you might do with this patient right off the bat when you meet them. Diet and nutrition, vision-related issues, mental health-related issues, cognitive, their support system, their motivation, So when you first meet someone with Parkinson's, I encourage you to really look at all of these areas, because you will find as the disease progresses that these areas, maybe not their social supports and things like that, but a lot of the diet and nutrition, vision, mental health will change as the disease progresses. So I want to tell you a little history of Parkinson's disease. It's been around since 1817 and probably before that, but Dr. James Parkinson was the first person who recognized these motor characteristics in some of his patients that he was treating. And then he also was walking the streets of France and was seeing that there were gait disturbances on the street. And so he wrote the original essay, The Shaking Palsy, and he kind of defined it as involuntary tremulous motion with lessened muscular power in parts not in action and even when supported, with a propensity to bend the trunk forward and to pass from walking to a running pace, the senses and intellects being uninjured. Well, as we see this diagnosis change, and maybe the definition of Parkinson's, we do know that a lot of these patients experience cognitive change as well. But after he wrote that Shaking Palsy, Dr. Jean Charcot took that information and expounded upon it and started studying it with his patients, and he named the disease Parkinson's. So that's kind of how it came to be. So like I was mentioning, Parkinson's disease is a neurodegenerative, progressive neurologic change, and it's really an issue with the dopamine production in the substantia nigra. And we do see that the cardinal features of this disease are rigidity, tremor, stooped or forward posture, and slowness. And so when neurologists first get these patients, these are the cardinal signs that they're looking for. We also see that patients with Parkinson's have Lewy body present in the substantia nigra, and some patients will obviously progress with Lewy body Parkinson's, and some will not. So we don't really know the effect of the Lewy body and how it will progress in the patient. So motor characteristics of Parkinson's. I think this is a take-home message for all of you. Once you see one person with Parkinson's, you've seen one person with Parkinson's. And so although we kind of categorize them on these cardinal symptoms or things that we observe, many patients are very different. You might not even see tremor, or you might not see the slowness or rigidity. And so these are some of the motor characteristics to look for. With us, we're looking for dysarthria, dysphonia, reduced volume. We look for that facial masking, swallowing related issues, and changes like that. So I always like to think of the tip of the iceberg is the motor symptoms, and then we have everything underneath, which are the non-motor characteristics. And I think that with research, we're starting to see that patients are providing us more information about things they were experiencing way before the onset of some of the motor characteristics. So if you look at that list, I mean, there's tons of people out here who probably deal with these issues, and it doesn't mean they have Parkinson's, but we're seeing that these factors are sometimes the early onset of the disease. I have so many patients that are like, oh, I've been dealing with constipation for years. I had no idea that was part of Parkinson's. And so I like to go over some of these symptoms with my patients on the first evaluation, because it really kind of helps me figure out the whole picture, not just dependent on the motor symptoms. Does anybody have any questions about any of that information? No. When you're working in acute care and you get a patient admitted with Parkinson's, do you feel like you get a pretty good case history on the patient, or is it you're kind of knowing what they're coming in for? Can anybody answer that? Like when you see people on acute, do you get a pretty good case history of the motor symptoms and the non-motor symptoms that they're dealing with?
It definitely depends, but I think more so in the outpatient clinic, if they've been thrown between neurologists, it's really difficult to pin down the exact context to what they've been on the path and this development.
Yeah, and in the neurology piece, when you get a patient, are most of your patients being referred to you by a neurologist or primary care? Where are you getting your referrals from? neurology? And is it a movement specialist or is it just a general neurologist?
I get both.
You get both, okay. So in Colorado Springs, we don't have any movement specialists. And so there are some neurologists that specialize in neurology, or I'm sorry, in Parkinson's, but they've never done a residency in movement disorders. So oftentimes I see this trial and error with some of these patients, like I think it's Parkinson's, but I'm not really sure. And so if I have a younger onset and I'm really struggling with some of the motor and non-motor characteristics to determine if it's truly idiopathic Parkinson's, I might send them to a movement specialist. I know we've got many up in Denver area or wherever you're from, but if you have somebody near, it's not a bad idea to have the person evaluated. So that kind of leads me to this next slide, diagnosis. So like we talked about, there's these cardinal motor characteristics of Parkinson's, and then there's these non-motor characteristics. And we have 3 levels. So we have definite, probable, and possible, which is interesting for a neurologic disease. So probable is a good sign. They probably have Parkinson's, okay? Possible is they're showing some of these motor characteristics, but maybe not all 3 or 4 of them. They may have some of the non-motor characteristics, but the progression and trajectory of these patients could change. So a definite diagnosis would be autopsy to determine if somebody truly has Parkinson's. And I don't know about you, but I know a lot of patients who want to sign up for that study. So, so we're basing a lot of diagnosis on probable and possible criteria. And in the neurologists that I've spoken to, they just said, you know, I like to start with this general Parkinsonism diagnosis, which is kind of the umbrella term for these people who are showing these characteristics. And as they kind of wean through the funnel, then we start to see maybe it's idiopathic Parkinson's, which would just be a dopamine breakdown and production issue. We then see secondary Parkinsonisms that are brought on by like toxins, drug use, tumors, so it's a different etiology than idiopathic Parkinson's. And then we have the Parkinsonian plus syndromes that are like PSP, MSA. They look like Parkinson's in the beginning, but then the progression is much different. And so, you know, I'm careful to use Parkinson's diagnosis when I first see a person because it's a heavy bag to carry. So I always, you know, really in my evaluations focus on what are their symptoms. I'm going to be monitoring you. I want to see how this progresses, and I'm going to provide your neurologist as much information that I can. And that helps the neurologist because they get 30 minutes with the patient to try to figure out where we are in this Parkinson's diagnosis. Any questions on that? Yes?
Just kind of stepping back.
Yeah.
You have the little iceberg underneath.
Yeah.
You said olfactory changes. Could you elaborate on that? Do you mean like a loss of smell and
Yeah.
sensitivity? What do you?
Yeah, so both. So taste and smell we see, and that onset usually is like 10 to 15 years before the Parkinson's diagnosis. And so there's a study out there, and I don't want to quote it specifically, but they looked at DAT scans, which is a scan that really looks at the production in the brain of dopamine. And they were finding that patients who finally showed the cardinal signs of Parkinson's were actually only producing around 30% natural dopamine in the brain. And so, you know, that's really interesting because when a person's diagnosed with Parkinson's, they've been living with this disease for years before actually getting diagnosed. And that's what I try to tell my patients. You know, prior to this, you've still had Parkinson's and you've been dealing with the effects of it. It just maybe isn't as big of a part of their lives, you know, causing mobility issues and things like that. But yeah, so that is an early onset characteristic that we see in this population. Great question. So some general facts about Parkinson's. 1 million people in the United States, 6 million worldwide. It's the second most progressive neurodegenerative disease that we have. It can be brought on by occupational hazards. Being from the Midwest, we had a large population of Parkinson's. Coming out into Colorado, we have military here who were exposed to Agent Orange, which is a qualifier for Parkinson's. And they're even finding out with some of the other wars that they were exposed to toxins that are leading to a Parkinson's diagnosis. So 15% of cases are heredity, and a lot of neurologists say that they don't, how do I say that? Neurologists try not to go on this family projection. I do have a lot of patients though that you find out had a grandpa, a grandmother, somebody in their family that was diagnosed with Parkinson's. And I think this number is going to increase, but the research just isn't there to support it yet. Diagnosis can be as early as somebody who's 20, and the likelihood of being diagnosed before the age of 40 is 5%. I do have a few patients that are pretty young. I have a few that are in their 30s, and a few in their early 40s. And those cases are really tough because they have jumped from one neurologist to another. They've gone to Mayo, and they're just not showing these major motor characteristics, but something neurologically is wrong. And then they try them on carbidopa, levodopa, and they see that the patient improves. So misdiagnosis rate of PD is 10 to 25%. That's kind of high. Yes?
On the hereditary
Yeah.
line, my dad has Parkinson's.
Okay.
He's being worked at NIH, and he's just there 2 days ago, and he told them there were 90 more hereditary markers that they found.
Oh, really? Yeah.
And that's like brand new. Like they're just starting to roll that out. So I think you're right. I think the hereditary thing's about to be a little bit.
Yeah, and they did that 23andMe thing, and all of my patients got it in the mail, and they're like, I get to find out all this stuff. I'm like, are you sure you want to know what that's going to be? And yeah, they found some markers, but 90, that's incredible. So misdiagnosis rate is 10 to 25%, and like I said, are we really evaluating the people who didn't sign up for studies for autopsy, so we could be more off from this misdiagnosis piece? So I talked to my neurology colleague, and he said, oh, you're gonna go into medications, I don't know if that's a good idea. And he said, well, I'm gonna give a little general overview of medications, but the most common medication you're gonna see that your patients are on is carbidopa, levodopa, also known as Seniment. Seniment in Latin means no puking. So that's kind of the goal of that drug. And carbidopa, levodopa has been around for a really long time. The only thing that has really changed at this point is that it's how we administer it. So I know there's new inhalers on the market. There's these like Listerine patches that you can put on the tongue that are quick release types of levodopa, and we'll talk about that in a second. But another drug that I see used widely is Rytary. It's an extended release carbidopa, levodopa, and typical of what I see, and you guys can correct me if you see other things, but most patients who are early diagnosis, you'll see them put on 1 tablet 3 times a day. Is that kind of common? Yeah, okay. And so then you kind of see these dopamine agonists. I also see that used a bit. And the ones I see mostly are Mirapex and Requip. And then we have the inhibitors, and on those I see Solageline, and I think those are the big ones. Or an Azilect was used a lot before, and we're finding that drug really wasn't as effective as we thought. And then amantadine I've seen with some patients as well. Any other drugs that you guys are seeing used? No? Okay. So just to go over the terminology, it's really important for us to know these medications and be able to talk about them. Your patients will trust you more. So if you can ask, how many dopamine are you taking a day, or Seniment are you taking a day, it just makes them relieved that you know what they're specifically on for their Parkinson's meds. And so L-Dopa is, it metabolizes into dopamine in the brain, and the carbidopa piece of that is to reduce it breaking down in the bloodstream, so the levodopa can make it to the brain, and it acts as a synthetic form of dopamine. The inhibitors, it really blocks the enzymes and breakdown of the levodopa, and the COMT inhibitors, those are reducing the wearing off effects. I'm not real convinced on those. I haven't seen that be very effective in use with carbidopa, levodopa, but I see some of my patients are on those types of drugs. And I see those more, are used more with my younger onset patients than my patients diagnosed after the age of 70. So with all of those medications, you can see the side effects. And so those are things you want to be watching for and asking your patients, are you experiencing any of these side effects from the medications that you're on? Okay, the neurologist, like I said, gets 30 minutes. So they're going to see that patient, we're going to try this drug, and I'll see you in 6 months. So they just kind of hope and pray that it's going to work out for the patient. So medication considerations, terminology I like to use. Do you ever feel like the medication is wearing off? Do you experience like on and off symptoms? Do you experience a delayed on? Scheduling. I don't know about you, but that has been real tough with some of my patients. They're like, well, I got up at 6 today, so I think I'm due at around noon. And I'm like, well, how many hours are you between your medications? So I'm kind of a boot camp master on that. Medication needs to be consistent. The only way we can judge how it's working is if we know how it's working. And so if patients are kind of taking medications at whim, that's something to ask the patient about. You know, did your neurologist discuss with you when you should be taking your medications? How many hours between? I do have some neurologists who are a little laxed in describing what the patient should be doing. And so I have patients who are taking, you know, one at 6 a.m., one at 1, and then another at 8 p.m. And I'm like, did they describe that that's the schedule you should be on? Because that would not work from a dopamine perspective. Dopamine really lasts for about 2 to 3 hours in the system. Now, earlier onset people, they may have a longer timeline with that medication, but when we're going 8 hours in between dosages, it just doesn't make sense. So those are things that I ask my patient, and then I document. And then if I don't feel good about that, I'll probably call the neurologist and ask them what they recommend. So has anybody heard of the Tab Time Super 8? It's a pill box. Write this one down. It is the best. And I'm not working for this company, but it's on Amazon. I think it's like $25, $30. And what it does is it sounds an alarm, and it has 8 different slots for medication. So it sounds an alarm. If the patient ignores the alarm, the light stays on, and so they know they haven't taken their medications. And it carries in their pocket. So most of these people have to take medications at, you know, weird hours of the day, so you want those pills on them at all times. Yes?
Something else,
Yeah.
people will have that or won't carry that around, because I have people, they have a smartphone,
Yeah.
you know, and programs.
Yes, great idea. Yes, yeah.
More often, you know.
You're right. Yeah, and I see, they put them just raw in their pocket and they're pulling out, yeah. Like, where'd you get that? Yeah. There was another question?
No, I was just looking for the price of pound, it's $25.
Is $25? Yeah.
19.
25, going once, going twice. Yeah, so it's a really good, I like it, but yeah, the smartphone is an excellent idea too. So side effects of dopamine being too high is dyskinesia. So that's that involuntary kind of wiggly movement that you see with patients. Dystonia is another common thing that we see. If somebody's not metabolizing the carbidopa, levodopa well, you're going to see some tightening and contraction of the muscles. It gets a little scary when people are eating, because we see it a lot in the facial musculature, and they get very tight and they can't open their mouths. Chewing becomes an issue, so you want to watch for that. We can see increased freezing or rigidity. If a person's complaining of nausea, you know, the amount of milligrams of carbidopa, levodopa may need to change, and so that's something to document for the neurologist to know. Fatigue and anxiety. I do have a lot of patients who express an unsettledness when they take carbidopa, levodopa, and I kind of equate it to anxiety, but it's just this like jittery type of feeling. All things that I would document if a patient is experiencing any of that, because it really helps the neurologist figure out what to do with their medications. So this is a little video, and she is just such a sweetheart, but this patient is experiencing dyskinesia, and you'll see the rigidity, and I'll just kind of show you that. But you kind of see that involuntary movement. That's 24 hours a day for her. So she lives in a subacute rehab, or she lives in an assisted living, I think, yeah, assisted living center. And so I don't know how she's getting drugs administered. I'm not really sure. Her neurologist is following the dyskinesia piece, and dyskinesia also comes with the progression of the disease. So this may just be, she's had Parkinson's for many, many years, and it may be the progression of the disease. But I have seen her more, or better regulated, and that states that she's missed her pills. So it's interesting. Now, some patients choose to feel like this. They'd rather have more of that movement than being stiff and rigid. And so, I ask patients, how do you feel? What does this look like? I have patients who want to be on a low dose of cinnamon, but they have a pretty extensive tremor, but it doesn't bother them. So I make sure I get the subjective data from the patient as well. Any questions on dystonia, dyskinesia? Does that make sense? Okay. There we go. So determining your evaluation, and you guys fill in here if you get other types of orders, but I work in an outpatient setting, and so what I see is a lot of orders that say speech therapy, evaluate, and treat LSVT loud, because everybody's familiar with that one. Dysphasia, voice disorder, mumbled speech, and memory loss. Anybody else get different orders that they see for their patients with Parkinson's?
I get an order that says because of weight loss.
Because of weight loss. Okay. So assuming there's a swallowing issue, you think?
No,
or?
not necessarily. It can also be because of the dystonia.
Oh, right. So the movement, constant movement, and things like that.
That comes from the dietary.
Yeah.
So that's.
So what do you do with that? Do you get a clarified order, or do you kind of go with it? And you?
I do the whole thing.
Yeah. Okay. That kind of opens the door for you? Okay. And so when I do LSVT, I'm certified in LSVT loud and speak out. And I like the order to say that specifically, so I'll usually return it and say, I'm going to be doing a specific protocol. I want your permission of that type of treatment that I'm going to use, or I send my plan of care. I always, upon initial evaluation, determine what their perceived impairments are. Now, Parkinson's is a sensory-related disorder, so people may perceive things that aren't occurring. And I hear this all the time. Like, I saw it online, I'm supposed to see a speech therapist, I'm choking, sometimes things feel stuck, my pills aren't going down, my voice, yeah, it's a little bit softer, and I guess it's changed in pitch, and then my all-time favorite is my spouse needs hearing aids. That one I hear all the time. And so their perception of their voice is normal, because it's gradually declined over who knows how long. It could be 5-10 years that they've been progressively getting quieter, and so they perceive that as normal. And I also see that the families start to perceive that as normal. Well, he's never been a loud talker, and you're looking at decibel numbers and you're thinking, well, you're talking way below normal hearing level. There's no way this person was a teacher. So kind of piecing that together and educating your patients on that. I think this is so important, identifying the support system. These patients who live alone, it's tough because Parkinson's is a lifestyle. And so if you don't have people around you helping and facilitating in mobility and speech, voice, cognition, it's tough. And then, what I love about being more of a specialized Parkinson's therapist is that I get to do motor speech, I get to do voice, I get to do dysphagia, I get to do cognitive linguistic, language skills, communication, and so this population, you need to think of all of those variables with these individuals. These are common voice, subjective voice assessments that you're all familiar with, and so I won't really go into those, but I use these to collect some subjective data. I really find that their perception is very different than what their actual scores are. And so it's just to kind of see where they are in accepting the changes that have occurred because of Parkinson's. So hypokinetic dysarthria is the most common dysarthria that we see with individuals with Parkinson's. And you can kind of see the characteristics of hypokinetic dysarthria. And I'm gonna play this little sample for you, and then after, just kind of shout out some of the things that you're hearing in this individual's voice.
Parkinson's, and then we would extract different law sites in there. Did a lot of training when we took a lot of stuff over to the Philippines. I did a lot of training. When I was here, I wasn't there. I did auditing for the Philippines.
Okay, so what things did you notice? Say it again.
Low volume.
Low volume. Anything else?
Or freezing.
Yeah, right. Simple phrasing, you just kind of stick into the meat and bones of, or meat and potatoes of it.
No facial.
And no facial expression. No body movement for that matter. I mean, he's literally just stuck in this position.
And then poor breath loss.
Yes, yep. Poor respiratory support, absolutely. So it's resulting in that lower volume, more mono-pitch. You don't hear much inflection in his voice at all. He's a little bit hypernasaled, and he is dealing with disfluencies. I don't know if you can really hear it that well because he's talking so soft, but dealing with some disfluencies and hesitation in his speech. It's like he's got to kind of keep it going. And then obviously articulation issues. He's not as precise and clear in his speech. So these are characteristics that I look for right off the bat. So during my interviewing piece of all those questions, I'm going to ask about medications, perception, support system. I'm also doing a full analysis of what is this person's conversational speech and voice. And then I also look for all the body language issues. Obviously he's not moving much, so it's easy to tell that. So let's kind of go into the specific treatment protocols that are available. So LSVT, I'm guessing everyone in this room has heard of the Lee Silverman voice treatment. And it does have level 1 evidence. In order to do LSVT, you need to be doing the full protocol. 16 sessions, 4 weeks, 4 times a week, okay? And I know that that's hard. That's really, really hard, A, to get people to come 4 times a week, and B, pay reimbursement and things like that. Does anybody in here do full-on LSVT with every patient that they see? And you're able to do that?
Okay.
Yeah, okay, wonderful. And it has great outcomes. I mean, it works, but you need to do it in its consecutive sequence. And that's where the research lies. So if you're doing the full protocol, your patients should have benefit for 2 years after completion of LSVT.
I have the luxury of being outpatient.
Say that one
I
more
have
time.
the luxury of being outpatient.
Right, me too. Yeah. Inpatient, does anybody try LSVT or, yeah? And how does that go? Because they're gonna be leaving, so how do you do that?
It really depends. It's usually not 4 days a week.
Okay,
It's, let's say they come on Wednesday and I start on Thursday. It's 2 days, then anytime I can come because it's LTAC and it's from 3 to 5 times a week depending on how busy I am. I try to make it a priority and see them at least 4 times.
yeah,
They get their homework. Many people don't do that.
uh-huh,
I try to learn on the helper DVD. Some people use it, some people don't. So it really depends, but I recently had a patient who put a great effort. We did, I believe, 5 sessions,
uh-huh.
and they referred them to home health.
And then had it continue from there?
Yes.
Excellent.
indeed.
Very, very good. And so don't be scared to start these patients on this, but then remember when they discharge, it's kind of your job to make sure that the continuum of care is there. LSVT and Speak Out, which will be the other one that I'll talk about, they both have resources on their website that show you clinicians in your area that are certified in these different approaches. So, for sure. So the target of LSVT is loud, obviously it's in the name, and it does require an ENT consult. Do you do an ENT consult on everyone? Okay, wonderful. And so that's part of their protocol if we're gonna follow the research and the outcome measures of what LSVT has created. That's kind of what you need to be following. So you need to be a certified therapist. So pre and post LSVT. So this is my gentleman holding an awe. It's long. Okay, and then this is him now after treatment. And you can just see by the two pictures that I have. I mean, he just looks more, he's moving more, he has more facial expression. And this is his odd now. I hope I don't blow a speaker. So it is effective in odd. But the nice thing about LSVT is they do this hierarchy of cognitive and speech tasks, and really the whole principle is that the person will generalize and carry over into conversation. LSVT and swallowing. And so they've done some pilot studies. I know that there's more research that has come out on this topic, but according to this pilot study, they basically saw that oral transit time and pharyngeal transit time were an issue with individuals with Parkinson's and swallowing. And after doing a controlled study, they found that after completion of LSVT, people were demonstrating improvements in oral and pharyngeal transit times, a reduction in residual, and improved, I think I just said that, transit times and things like that. But further investigation is warranted on this, and I've seen some other studies that have looked at speech and voice therapy and swallowing, and it's shaky. So I think personally, the people who are demonstrating like more mild, really mild swallowing symptoms, subjectively they tell me their swallow is better. And so I mean, if they're saying I'm not having any problems, I'm not coughing, choking, I'm not feeling like things are getting stuck, I think that's a great outcome. Now, my more moderate to severe patients with dysphagia, this would not be my treatment approach. And LSVT has a Loud for Life program, so it's a carryover class, and it's really to extend the principles of LSVT. Have you done the LSVT Loud training?
I've done the training, but I haven't done anything
With it, okay. Yeah, no, totally makes sense. And so this, again, is you must finish the entire protocol, and then patients can participate in a carryover class, basically to reinforce what they've learned during their treatment. Speak Out. Who's heard of Speak Out? Yeah, okay. So similar basis to LSVT Loud, but the whole target system is intent. And I really, between LSVT and Speak Out, I like this word intent because patients have a really negative connotation to loud. I mean, I hear, my dad always said I should be seen, not heard. I mean, we start going back to childhood, and I'm like, okay, we're just trying to get you louder here. So, so intent is another cueing word, same target. We're doing high vigorous exercise. It's a little bit more functional, so you do have to be certified in Speak Out in order to complete its evaluation and treatment. But sessions are about 40 to 45 minutes, 12 sessions 3 times a week. So I remember sitting in LSVT the first time and I was like, 16, why 16? Like, could it be 11? Could it be 15? And so I guess they just reduced the amount of intensity the person needs each week. The Parkinson's Voice Project is a nonprofit organization, and so each patient is on a pay-it-forward model. So if you're a certified therapist, your patient gets the workbook of exercises that goes along with your treatment, and it has cognitive exercises, speech, and voice. And so that's a really nice perk because your patients get everything in hand. And really the purpose of this therapy is to strengthen the muscles that we use for speaking and swallowing. Their whole principle is live with intent, and I really like this motto. I think the more that we can do things with purpose, the patients do better. And so Dr. Boone worked with the Parkinson's Voice Project, and really they talked about this extrapyramidal tract versus the pyramidal tract. And the extrapyramidal tract needs dopamine. And the pyramidal tract can be activated through purpose and focus and intent. And so although the extrapyramidal tract is controlling all of our automatic functions, and that's what we see decline in Parkinson's, the pyramidal tract, it's not as pretty and it's not as smooth, but people can still do things by activating that system. And so A lot of my patients, they live with intent, they walk with intent, they speak with intent, and it's really just doing things with purpose. And so I see a really good buy-in on that, and patients use that. So, and the other thing I would like to say about Parkinson's Voice Project, it's very inexpensive to get certified. I think it's like $200. And then you get the whole resource kit for free. So something to think about. And if you've never treated Parkinson's, or you get one time a year, I think LSVT does a phenomenal job of really training you what Parkinson's is and the medications and things like that too. So both have their importance, I guess. Parkinson's Voice Project created the Loud Crowd, which is just another carryover class to work on these speaking out. Patients can participate after their 12 weeks of therapy, and it's really to just provide encouragement and motivation and accountability. So I run 2 classes a week of Loud Crowd, and I've worked with some of these patients for 3 to 4 years, and with the accountability, I mean, we talk about exercising every week, they get the lecture, but they really are doing very well when it comes to speech and voice. And I think with Parkinson's, we have to be acknowledging that it's a progressive decline. And so we need to be in their lives constantly in order to kind of reduce that progressive decline. Forte Exercises. So if you're not certified in anything, you could try some of these exercises. They've been more studied with presbyphonia and decreased phonatory effort. But these are some exercises where you're working on sustained phonation, which is similar to LSVT and speak out. You're doing pitch glides and then working with short phrases. The limitation of just doing Forte is it really doesn't have a hierarchy into generalization and carry over into conversation. Any questions about that? No? Okay. The breather. Has anybody heard of the breather? Yeah. Okay, so you can order it on Amazon. We can all do the breather if we want. And it's really working on inspiratory and expiratory muscle strength training. It's lower resistance. So for my patients that are really struggling with breath support and just engaging the respiratory system, I might start them on something like this. And it helps kind of get that diaphragmatic breathing. It helps with shortness of breath, and it just kind of promotes better respiratory support. And their protocol that they have available is 2 sessions per day, 2 sets of 10 full breaths, but this isn't mandated under a speech therapist, so I mean, we all could buy this instrument and use it, but it's a good starting place for some of your patients who are struggling, and it also has been seen effective in swallowing related issues. EMST 150, does anybody use this? Yeah, okay. This is great for swallowing. And I think the research behind it proves that it really does help with swallowing related issues with Parkinson's disease. And the target is really exhalation and really getting that deep breath and pushing air forward through the vocal cords. I use this in collaboration with Speak Out or LSVT sometimes, depending on the patient. And this is a specific protocol that they want followed, so it's 25 breaths, 5 sets of 5 repetitions 5 times a day. It's not, I think the hardest part is just mechanically getting people to know how to hold their cheeks, make sure the valve is behind the teeth, blowing air forward. I had a patient just 2 weeks ago who was like, I think I was making moose calls in the basement. I'm like, that's not how this is meant to be used. So I messed up and I didn't train him correctly. So making sure that these patients really know what they're doing. Yeah.
Before you buy that, it's worthwhile to just try the little spirometers, that are not spirometers, but the inhale and exhale thing that you get when you go to the hospital.
Yeah, yep, just to see if they can activate it, because this is way more difficult.
You can change it for inspiration and for expiration.
Yep.
So.
Yep, and I've even done like straws, like can they blow a tissue, you know, just to see if we can get enough.
Because even though this isn't that expensive,
Mhm. I think it's like $50, something around there, 45, 60, okay. And you can order it on Amazon, so I usually send my patients there to order it. But yeah, great suggestion, for sure. So dysphagia, and after Dr. Coyle's presentation today. I feel like I know nothing, and I'm just gonna have to go back to a lot of things. But so dysphagia is very, very common in Parkinson's, and so we have to be watching for the early signs and symptoms of swallowing issues. Drooling is an early onset symptom of dysphagia. Difficulty with pills. So most of my patients that I see, I do recommend a baseline MBS, and I just want to know where they're at. Most of them are going to pass. And going back to that extrapyramidal and pyramidal tract, when somebody's sitting there, you're telling them to swallow, they're in this perfect environment where there's not a lot of distractors, they swallow really well. And then they come home and they have the TV on, they're talking and they're trying to multitask, which we know in Parkinson's does not work, and then they're choking. So I like to kind of know if there's any functional impairments with the patient, and then I always watch them during therapy. They always have water. Sometimes if they're talking about solid dysphagia, I'll make sure that I'm bringing in things to try to see how they do in a more functional environment. So clinical swallow evaluations, you're kind of looking for the typical signs of problems with swallowing and eating. Biggest thing that I see with Parkinson's in the early phases is timing and coordination and sensory reduction. So you see that sometimes they take a drink of water, they're fine. The next time they take it, it's like they didn't take the right breath, they're incoordinated, and you hear that audible gulping like they're trying to catch up. And so watching for those signs and symptoms. I'm not a big proponent of changing diets with people who have Parkinson's. We know it's progressive and degenerative, and I want the patient to be on the most functional diet for as long as I can keep them on it. So I'm really, I guess I encourage you to think of other ways to support the swallowing issues than modifying like thickened liquids or purees and things like that. Traditional swallow therapy works with these patients because it's exercise, and so getting the patients exercising and strengthening is really important. I use the EMST. There was a poster this weekend on the IOPE, and they were talking about tongue pressure and better transit times, and they had a really limited study size, but they were looking at if there was some improvement. And one of the patients, there were two, one of the patients did much better on her swallow study. And looking at oral mastication and transit time, so something to consider. And then, like I said, LSVT and Speak Out both make claims that by doing those therapy approaches, the patient will have improvement in swallow. Cognitive disorders in Parkinson's, this is very complex. So, yes, yeah.
Sorry, before you move on, do you have any recommendations for the drooling? Because I get a lot of people,
Yeah.
that's one of the most troublesome things to them.
Okay, so a lot of neurologists are going to put them on a dry mouth type of medication, and so we see that. I don't love that because I feel like it's a crutch, and then that starts to, they override that, and then you find that they're drooling more. And there's Botox injections in the salivary gland. Again, I'm not a huge proponent of that until it's really, really needed. So these are some small tricks. I tell them to chew gum, because it just gets the mouth activated and gets them swallowing more. Ginger helps with kind of increasing salivary production, which then makes them swallow more. Ginger ale, lemon water, those are kind of some tactics to just kind of give more sensory response. But I go back to that intentional thing. You need to do it intentionally. So you're watching TV, every commercial, I want you to swallow, and just kind of making it more purposeful. But I have had patients who've gone in for Botox, and yes, they have relief for about 3 to 6 months, and then they are worse because they've lost the motor planning to manage their secretions. Is that kind of what you're seeing too? And the two gum types are cinnamon and watermelon. Yeah. Yeah. Those are two specific ones. Bubblicious, no, I'm just kidding. But yeah, cinnamon and watermelon just seem to help with salivary production and swallowing. What?
Do you know why?
I don't know why. I think with cinnamon, I would just predict because it has more of a sensory response, and I think watermelon is really sweet and the same kind of thing. Yeah. So cognitive impairments. I mean, this is so wide with your patients that you're going to see. Some have mild, some have more severe, and I like to do the MoCA, and it's in the research a lot as a standardized kind of screener of how people are functioning cognitively. But if I think that the person's more on the moderate end, I'll do the R bands to look at the specific areas of cognition. And the RIPA and the CLQT, if you don't have the other ones available, would be fine. Kind of giving you a gist of where the patient is at. I'm really lucky because the physical therapist I work with is so in tune with cognitive related issues, and so she'll usually come to me and be like, oh, he can't multitask and he can't do this and this and this, and so I basically know exactly what's going on before I see the patient. So according to the study, really the areas that we see, and I like this study because it really outlines the specific deficits in Parkinson's, is that we see a decline in verbal fluency, so people have more hesitation, word finding issues. If you do a verbal organization task, you see a breakdown around 8 items and then they're just stuck. Slower processing and inattention. Well, that affects everything. So inattention, that's going to affect your word finding, that's going to reflect or impact your memory and your ability to dual task and things like that. So any other cognitive areas that you see with your patients? Yeah.
I think on an earlier slide you had impulse control.
Yeah.
And I wondered if you know anything about people who did have Agent Orange exposure, and if there's any stronger relationship there.
You know, there was a newer thing that I was reading about Desert Storm, and some of the people who came out of that were dealing with Parkinson's, but like more impulse behavioral issues, like dementia. I mean, more associated with like a Lewy body dementia. I do see impulse control issues with DBS as well, deep brain stimulation. Initially, they are doing pretty well, and then as the disease progresses, they are become very unsafe because there's just no safety reasoning going on. I mean, you just see this unfiltered, I'm gonna get up and move, and then they bump into the chair, you know, that kind of stuff. So impulse control, though, in idiopathic Parkinson's without DBS, I typically see it more in the moderate phases of the disease, like behavioral changes and things like that. Did that answer your question? Agent Orange, I guess, would be similar. I see more with Agent Orange of dementia that goes along with that, Lewy body dementia, Parkinson's, in some of those patients. So carryover, we need to be thinking about function. It has to be functional because Parkinson's is an everyday fight. Every day they're gonna wake up with the same disease and have to deal with the symptoms of it. And so I always tell my patients it's a lifestyle. This is your full-time job. You're gonna clock in and clock out at the end of the day. And the more that they buy into that rationale, the better they do long-term. So these are some activities you could do for carryover. Pretty simple activities, but the biggest thing that I see with this group of individuals is social isolation. They're really good listeners, they're not great talkers. And so I try to really get them engaging in the community and recognizing that they can communicate and be very functional. But sometimes by the time they get diagnosed, we've got years of social isolation, losing friends, hobbies, and we are kind of rebuilding the person back. A good thing to know about Parkinson's is push these patients. They look frail, they look like they can't do things, and I have seen people from wheelchairs walk across rooms because when they're pushed and motivated and they use these principles of intent, you can see people do really incredible things. So remember that, don't be scared of this population. So dual tasking, obviously doing something simultaneously. We know with Parkinson's that is very, very difficult. So most of them are singular task oriented. But we want to exercise it. We don't want people to lose that function because if we always make them do something in a singular task, they may be successful, but that's not functional. So when they're at home and they're cooking and then they're walking to the sink and they're talking, and there's just an array of things that can go wrong there, but that's what you want to exercise in therapy. So we start with maybe speech and voice or dysphasia treatment or cognitive treatment, but as we progress with these patients, we've got to be thinking about how do I get this person back home in the community and for some of them back to work or working for a longer period of time. So according to Wu and Hallett in 2008, they did a research study looking at dual tasking and what is really dual tasking, motor versus cognitive, and do we make the motor task way more difficult and the cognitive less, or how do we do this? And so what they really found is that the motor task being priority didn't always induce this interference of cognitive change. And so people, when they were marching or passing a ball back and forth and there was no real difficult cognitive component, we didn't see a breakdown. So it's usually with the cognitive piece and then the person having to do something from a motor standpoint that might be more simple where we see that interference. So this is an example of maybe a task you can set up. And the patient is just asked to move around these objects. Now there's no verbal component to this. The cognitive is really forward, directional, stepping. The person is focused on making sure they're following the sequence, and then requested to switch directions. I think this person's moving pretty well. And that was when she was asked to switch, and so then you see that hesitation and gait to kind of restart the system, but does very well with this. To increase the complexity of this task, you could have her start saying colors. I mean, that could be the first level of dual tasking. You could say, I'm going to say a pattern, and as you're moving through this obstacle course, I want you to repeat the pattern that I just gave you. So orange, yellow, blue, purple, and then the person needs to move at the same time. What you're going to see, and I don't have video of that, but what you would see is that now all of this nice stepping forward, backward, all of that going on is going to start to decline. So you're going to see this fascinating gait, the person might start tripping, the steps will become smaller, and so this might be a good task because this is kind of like navigating around a kitchen. The next one I'm going to show you is where the physical task probably outweighed the cognitive, and so it wasn't that hard for this patient to keep moving.
22, 24, 26, 28, 30. 32, 34, 36, 38, 40.
So in that dual tasking, she's not really being pushed cognitively, and so she's able to kind of dual task, marching in place and keeping rhythm and counting by twos. So for this patient, it wasn't hard enough. So we got to kind of push the hierarchy on this. And the next patient is cued to bounce the ball back and forth. He needs to switch categories. So the category was a sport and a state, while keeping his voice forward. And you'll see him this taxed him too much. We overloaded this task.
Golfing, California.
So now we start to see more of the tremor coming out,
Arizona.
instability.
Hockey, Canada. Baseball, Nebraska.
Okay, so you kind of see he started strong and then we progressively declined as that task got too complex. So for him, I might just start back to the beginning. Let's just get this ball going, okay? Let's do one category at a time. And, you know, I see a lot of therapists want to push cognitively beyond what some things that we can even do, and that's not fair. So any task you give somebody, make sure you're doing it and you can do it before you have your patients do it, okay? Because some of our patients are doing really well, and then we're like, well, now I want you to climb a mountain, go ahead, and it's not really fair for expectation.
Golfing.
So feedback, accountability is key. You need buy-in with these patients. It's so important. That first evaluation can be detrimental to the trajectory of their disease. I've had patients who, you know, I ask if they've had speech therapy before, and she saw me like 2 or 3 times. I don't know what the point of that was, and I'm fine, things are fine. And I think we're missing how important it is that first encounter needs to be the best encounter, because this is forever. This is what they have to do every single day. So even if you're not that comfortable with treating Parkinson's, we're relying on this motivating, hey, this is a lifestyle, you need to stay active. Doing those things can really change how a person perceives their disease. And so establishing goals that are functional, you know, phonation exercises, that's what we're doing in LSVT and Speak Out, but what is that for? What are we working on? So making sure that, you know, I always have my patients part of my goal expectations, and so we're both on page measuring if they're progressing or not. And that keeps them doing their homework because they want to succeed. modeling and imitation, LSVT really has done a lot of research on this, but individuals with Parkinson's do not do well with over-instruction. It's too much information, they're probably not paying attention. And so the best is to model. And so I always say, I'm a cheerleader. Like when I go to work, I turn it on all day long. And so if you want your patient to have facial expression, you better have great facial expression. If you want them to have body movement, you better have body movement. So I've had new students come in and train with me, and they're like, you're just so high intensity all day long. And I say, yeah, I'm modeling what I preach. I want my patients to copy what I'm doing. And if we're here and they go here, we're getting them back to normal. So that's kind of your goal as a therapist. And I've had a few students who say, this isn't for me. I can't be at that energy level all day, and that's okay. That's totally fine, but these patients deserve it because they're watching what you're doing and they're learning from that. So examples of feedback that I use. I really think loud, obviously LSVT, speak with intent, which would be the Parkinson's Voice Project, but I like to use visualization goals, like throw your voice over my head, hit the wall. I put targets all over the wall. I want you to hit on the left wall, right wall, go. And if you help them aim, they kind of understand there's like a target that they're going for. But if I say, what, huh, do that again, how do you measure that? What do you want me to do again? Obviously I did it wrong, but I don't know how to do it right. So giving them something to focus on and project. And swallowing, same thing, kind of like we were talking about before. I'm gonna have you try during this therapy session 10 just swallows. I wanna see that you're in control of your swallow. And setting goals like that, so they're thinking about purposefully swallowing or blinking or anything like that. Where am I at?
203.
203, okay. So internal versus external motivators. So I really see that at first, these patients need a lot of external motivation, like family support, friends. You know, I get them calling people they haven't talked to in 15 years because I just want them to start creating more of a social outlet for themselves. And like I said, that cheerleading role, you know, any improvement that you see, wow, this is really working on this area and look at how much better you're getting, is so beneficial for buy-in. You hope that if you're really, really good at external, that it becomes internal and the person becomes internally motivated to fight back against this disease. I also always encourage the family to come to my initial evaluation. I think if you can get them on board, the patient will be on board whether they want to be or not. But that it's really important that you're educating the family and what does this look like long term. Now if they go on Google, they're gonna think that they're dying in the next year. And that's not how this disease goes. We know that with exercise and accountability, these patients do very, very well for a very long time. And I think in Dr. Coyle's presentation, the big thing I took away from that was reduction in mobility, not moving, not being active anymore. And this population is known for that. They continue to decline until they're kind of sitting in the corner, not moving much. And they don't look safe. And so their family kind of encourages, hey, don't move, you're better there. Well, and that inactivity is ruining everything. I mean, we're gonna get poor voice production, we're gonna have swallowing issues, cognitive decline because of social isolation. And so really trying to keep these patients as mobile as possible for as long as possible is the best option. So that kind of leads me to exercise classes in the community. I know in Denver we have tons. There's power punching, boxing program, there's dance classes. Colorado Springs has treadmill training. The YMCA's are like, there's so many resources available. A patient should never leave an evaluation without knowing what other resources are available. So kind of educate yourselves on those things and make them part of it. I left this for the very last piece, and I think it's the most important piece. So it was good of me to leave it for the end, but I think emotional health is something we really, really, really need to pay attention to. And when you are reading some of these case studies, you see these people, their motivation or their mental health started to decline. A lot of them are experiencing anxiety and depression. And depression is different in Parkinson's than it is for us. It's a different neurologic depression, and apathy is real. And so we have to be considerate of those factors, making sure that if you think that a patient needs counseling, you should be referring. I mean, that almost takes priority over speech and voice. If you think that they're really on the depressive end, that's something you want to document to the neurologist so they're at least considering, okay, there's this other piece to this person, and making sure that they get the help that they need. I always encourage my patients to get back into their hobbies. I have a lot of musicians and artists, and you just see that they stop doing it. And then I'm like, well, why? Well, it's not as easy as it used to be. Okay, well then you owe me 5 minutes every day. You've got to sit and play the piano, or you've got to paint something. I don't care what it looks like, but you've got to just keep that going, because you'll see that as they start to reintroduce themselves, they find a different passion for it again. So encouraging getting back to their baseline in those things. And apathy is such an important word. It's low motivation. This population is known for low motivation. So they're not going to leave your therapy session and be like, yay, I get to exercise every day for the rest of my life. Sounds exciting. And so you really need to get them to buy into why are you exercising, what is the point of this, and really providing a lot of encouragement. So I like to always think in the back of my mind, where is somebody in the coping process? Where are they? And so, you know, when you've seen 3 neurologists and you've been diagnosed with ALS and then maybe PSP, Lewy body dementia, and you finally get Parkinson's diagnosis, I mean, that person's been through a lot. And we're really at the forefront of helping them through that coping process. So taking an active role in that is very important. So based on your